Good afternoon, everyone. So this is going to be a hospice educational forum, and there will be an opportunity to ask questions at the end. So I just wanted to introduce our guests. We have Dr. Mayford. He is a hospice medical director. We have Patty. She is a nurse who's worked in hospice for many years. And then we also have Bill, who is someone who's had personal experience with hospice services. So you'll get to hear from all three today, and then, like I said, at the end, there will be time to ask questions.
All right, thank you all for having us here. As she said, I'm Dr. Joe Mayford. I'm board certified in internal medicine, board certified in hospice and palliative medicine. So thank you for having us. For our veterans, thank you for your service. So starting with that veterans theme, those of you that remember the series MASH, there are two rules in medicine that I learned from watching MASH. Henry Blake said, rule number one in medicine is patients die. Rule number two is doctors can't change rule number one. So we all know we all will eventually meet our maker. There are two ways we're going to go. 20% of patients will die of an acute illness, a heart attack, a stroke, acute infection, a bleed. Those patients, they're not hospice patients for the most part. The hospice patients, pretty much the 80%, the rest of us, that will die from chronic illness. And we'll talk about some of those chronic illnesses. So what exactly is hospice? Hospice is medical care for patients that are expected to live less than 6 months. So if your doctor's told you you've probably got less than 6 months of life left, then hospice may be the option for you. Hospice is provided primarily where the person lives. It's end-of-life care. Hospice provides an interdisciplinary team of professionals trained to address the patient's physical, medical, psychosocial, spiritual needs at the end. The team focuses on the person, not so much the illness. It's about making the patient comfortable during their last few days, weeks, months of life. That's what hospice is about. Many people think hospice is a place to go when you die. That's not so. Hospice is a philosophy centered on the rest of your life, providing you the dignity and comfort that you want near the end. Hospice is not about giving up care. It's about changing the focus of care. So hospice is not about looking for curative treatments, but it's about doing what you want, what the patient wants, what the family wants. And for the most part, that's keeping that loved one comfortable during those last few days, weeks, and months. What are the benefits of hospice? Hospice provides experts that are skilled in managing pain and other symptoms that you experience near the end of life. Patients with heart failure, for example, they have issues with shortness of breath. A lot of cancer patients struggle with pain, struggle with nausea. That's what hospice focuses on. When your doctor's told you there's nothing more we can do for the cancer or the heart disease, there's nothing else we can do, or the patient with dementia that's now bedbound, can't get around, and they're struggling, that's where hospice comes in and makes those people comfortable. Hospice allows you to stay at home or to stay in the place that you want to be. It helps avoid hospitalizations. It provides practical help, medication, and personal care. And that's what we want for ourselves, and that's what we want for our loved one. So hospice care, it is a Medicare benefit. Anyone that's enrolled in Medicare or Medicare Advantage, this is a benefit that you've been paying into as long as you've been working. So this isn't something that you're going to pay out of pocket for. This is something you've been paying for or that you've paid for during your working days. So again, it is a benefit that you have paid for. What hospice is not, For the most part, again, hospice does not provide curative treatment. That's not what hospice does. When you come to hospice, or when the patient comes to hospice, their doctor has already told them pretty much there's nothing else we can do. This disease state, whether it's a cancer or dementia or heart failure, we have no other options left to benefit you. Or you've decided, I've been through cancer treatment for a year now, 2 years now, it's not working, I'm feeling worse, it's not helping me, I don't want this. Hospice, again, is not curative care, it's more comfort care. In most cases, hospice does not provide 24-hour care. Some people think that hospice is going to provide 24-hour nurses around the clock. There are some instances where that is done, but for the most part, the care that you're receiving is usually from family members, nursing staff, or other residential care. Hospice does not hasten death. Instead, it focuses on providing comfort at the end of life and supporting the dying patient and the family members. So what conditions are appropriate for hospice? Pretty much any condition is appropriate for hospice. Any condition where it is felt that the patient's life expectancy is less than 6 months, whether that condition is a cancerous diagnosis, whether it's dementia, heart failure, chronic lung disease, chronic kidney disease, chronic liver disease, ALS, MS, stroke, any condition, whether it's end-stage osteoporosis, whether it's, we've had gallbladder disease, we've had, let's see what other, appendicitis, anything that is determined to be a terminal diagnosis or a terminal prognosis less than 6 months could be a hospice diagnosis. So again, any diagnosis can qualify. So in general, again, patients are eligible for hospice if it's felt that their prognosis is less than 6 months, if the condition runs its typical course. So what are some of the services that hospice provides? You have a hospice team that's going to care for you or your loved one. This includes visits by medical staff, could be the physician. It's definitely a nurse, social worker, nurse's aide, home health aides, a chaplain, spiritual counselor. All these people are involved in the care. Medications for symptom control are all covered by the hospice benefit, whether it's nausea, whether it's pain medication, whether it's itching, any type of symptom that the individual is having at the end of life, those medications are covered by the hospice services. Medical equipment that you may need, whether it's a hospital bed, a wheelchair, a bedside commode, all those types of equipments are covered as well. Volunteer services are covered as well. In the case where symptoms we're unable to manage them at home, then there's an inpatient hospice service that can be provided as well. There's a respite care. For example, if the caregiver needs a break, you've been caring for your loved one for months, you need a break, you're falling apart, there is what we call respite service, where the individual will go for 5 days to a respite facility, and that allows you to have a break. And this is all covered by hospice. Hospice also provides bereavement, grief, and loss support as well. So I believe that's pretty much the little intro to hospice that I had. Yeah, so Patty, I'll turn it over to you. And we will take questions when we're done, after Bill speaks.
So I'm Patty Hudak. My role right now currently is that I'm a nurse liaison with the hospice company under Dr. Mayford, who is our medical director. So once a physician deems or determines that a patient is within that 6-month prognosis, then my role is to come in and have that conversation with the patient and their family, their loved ones, and if they live in a community, to discuss that with the community. I talk to them about the services and what they can expect specifically based on their diagnosis, and how we'll support them, what nurse visits will look like, what the hospice benefit covers and what's outside of that benefit. And then I coordinate that admission. So the next steps after the family and the patient are agreeable to service would be to coordinate an admission nurse to come out and complete that admission. That admission nurse is looking for all of the medical terminology and evidence that the doctors have documented saying that this patient is eligible and has a 6-month prognosis. And then that nurse is going to call our medical director and review that case with him and make sure that that patient meets those Medicare guidelines and can be admitted to hospice service. From there, their hospice team will see them and takes over their care. If it's in a community, it's collaborative, so you don't lose your doctors when you come on service. If you have the in-house doctors here, Dr. Shear, Dr. Cook, and their nurse practitioners will still be able to make visits for you. Dr. Mayford works collaboratively with them. And the goal of the nurse when she makes the visits is to evaluate for the symptoms that Dr. Mayford reviewed here earlier. So things that are specific to that diagnosis, but even outside of that, because we're treating the whole patient. So if a patient comes on service and they are at end-stage dementia or Alzheimer's, but they have hypertension, we're not going to ignore the hypertension because it's not related to the dementia. We're going to manage that hypertension for them. We're going to change their medications. We're going to make sure that they're comfortable, and we'll treat those symptoms. So when the nurse comes, she's evaluating for changes like that. She's determining what changes within medication or physically need to be made. She's going to discuss that with Dr. Mayford, and then she's going to also discuss it with the physicians here in the community so that they are agreeable to treatment plan, and then she writes orders and implements that treatment plan. So if something happens outside of her visit, maybe even the same day, evening or afternoon, then we have a 24-hour service. So hospice is not at bedside 24 hours, but we are available 24 hours. So we would get a call, and our nurse would come out and make a visit and address those changes to make sure that the patient is comfortable, whether it's in the middle of the night or in an afternoon, same-day visit. The nurse is always looking to coordinate care. So that means any changes in hospice aid visits or the hospice care plan. Some patients come on service and they're fairly independent. They can shower themselves, maybe they need a standby assist, they need very little assistance in regard to aid and help with their hygiene care, but those things change as their disease progresses. So that nurse is looking for those changes and when that assistance needs to come in so that we can implement more hospice aid visits and make sure that patient's getting what they need, as well as the social worker that Dr. Mayford spoke of and chaplain services. Those are great social visits as well as support, but they're also helpful visits for the family as well to help ease their concerns, prepare them as much as we can on what to expect as the disease progresses, and how to support their loved one as they begin to transition. So with that being said, as far as your hospice team goes, I'm going to turn over a very wonderful, very diverse experience that Bill Bateman had here with his family that took place maybe over about 5 years with his wife, Sarah. So if you would like to come up, Bill, and share your experience, we'd love to have you. You can adjust that however you need. I think I'm shorter than you.
Well, as I have said, my name is Bill. I have a long-term experience with hospice that I wanted to share with you because hospice for us was really, really fantastic. I had 2 prior family experiences to hospice before my wife, and I'll explain that in a couple of minutes, but both my dad went through hospice before he passed. He was in hospice about 2 years, got great service with them, and my mother-in-law, Sarah, my wife, who has passed, her mother also had hospice service as well, also good experiences. The reason I even mention that is because different hospice companies or services worked with us in 3 different ways, and the service that we got from all 3 was outstanding. I'll move on to my experience, which actually started in 2002, so that's a long time ago. My wife was diagnosed with brain cancer. We went through brain cancer treatment at UVA, and After we went through a year of lots, and you talk about pain and all those kind of things, she experienced that. But about a year after she started with that, she was cured. And cured only means that, we are in remission. So anyway, she was in remission from brain cancer from about 2004, January of 2004, until 2016. 2016 is when it all fell apart for her. Let me back up 1 year. In 2015, she started experiencing issues that we knew were going to require extra help. I'm a resident of Lakewood, and we moved to Lakewood 10 years ago. We moved to Lakewood because she knew far better than I did that she was probably going to need some services. So we moved. We had 6 months together in our apartment before she had a brain bleed. That brain bleed put her in the hospital for about 8 days, and when she came out of the hospital, she was basically comatose. She had lost the day before she went to the hospital, she was up walking, eating, doing all the things that you do on a regular basis, the 7 daily habits that you're supposed to be able to do, doing fine. 8 days later, she was basically comatose and remained that way for about 2 months. Well, that immediately made her eligible for hospice service. Okay, so we were at Lakewood. They had several hospice services working within the facility at that point in time. So we looked around, talked to people, and decided on a service to use. And that particular service was, in our situation, just really, really good because they stepped up to the plate immediately. So back to my story, when she moved from the hospital to Lakewood Healthcare, and she went straight to healthcare. She was in the bed. She could not get up. She could not walk. In fact, she was basically, she didn't communicate. The first 2 or 3 weeks that we were there, the only thing that she got in her body was what we were able to put in through liquids. It was basically, yogurt was the thickest thing that she could take because she lost all control of her muscles in her throat. They didn't work. So I spent, of the 5 years that she was in Lakewood in the healthcare, other than the time of COVID when obviously we couldn't go see her, which was, that was hard. But during that 5 years, I was there with her a part of every day. And many days I spent many hours with her because she had to be fed. And I became the person who fed her. So I did that for a good long while. She stayed in that comatose state, however, for about 2 months. And we felt a miracle at the point in time, and so did everyone else. We had family or friends visiting from North Carolina, and we were sitting in her room. We being the couple of the friends and myself, were just sitting there, and Sarah, we had propped Sarah up in her bed so that she could at least see what was going on. And we've been talking probably 30 minutes, and all of a sudden she joined the conversation with us. She had not talked in 2 months, and she just joined the conversation just like that. Well, to everybody's amazement, and those kind of things happen with brain bleeds because her brain had rewired. Our brains are very, very, very interesting parts of our body that still we don't understand very well. But anyway, in her situation, at that point in time, whatever stimulated her, she was up. She was never able to, she could stand, but she was never able to walk. She could not get one foot in front of the other, so she was in a wheelchair. But she was up, and the physician immediately evaluated her and said she's no longer eligible for hospice services. And that, let me back up just a second with the hospice services during that 8 weeks. The CNA came in to see her every day, and they had like 10 people, that company had 10 people at Lakewood at that point in time. So she was basically assigned to Lakewood. And she started with Sarah every day. So she would start at 6 a.m. in the morning with Sarah's bathing, and she was one of these people going far beyond what she needed to do, what she had to do. She would sing, she would hum, the whole time she was bathing and doing all of the things that you do to make a person as comfortable as it can. She was doing it, singing the whole time. Sarah never responded that entire time. Got no response from her at all. But she kept doing it, and I kept going at 6 a.m. in the morning, which for me is hard because I'm not a 6 a.m. person. At least I'm not anymore. I used to be when I was working, but I'm not now. So moving along with my story, she did very well. She regained use of her hands. She was able to feed herself. Well, sometimes with assistance, they would have to cut, but she could take it and get it into her mouth. And she was always, from that point on, conversational. That was the one thing that made our 5-year experience different than a lot of people, because we were able to talk on a regular basis every day, many times a day. She could carry on a conversation. During those months after she was found ineligible for hospice services, we, of course, had physical therapy. She had physical therapy, occupational therapy, and speech and language, and they all benefited her. Unfortunately, and this happened, the brain bleed that got her into the hospital happened in May of 2016. Labor Day weekend of 2016, she had another brain bleed. And it was just like that. She was right back and couldn't do anything except she could talk. That was the one thing she could continue to do. But I had to go back to feeding her. Everybody had to do everything for her again. But at least she could express herself, and we had conversation. So she, again, became eligible for hospice service at that point in time because her diagnosis of her prognosis with the brain issues that she had is nobody knows how long you're going to do that. And they really felt it, the first time around, she was never going to even wake up. When we went in the fall from September on to that point, she was in hospice service for 3.5 years. And we had the services that they had talked about on a regular basis. We had a wonderful nurse who would come 2 and 3 times a week, and we would have conversations. She actually obviously became part of the family for us. And I have 3 sons, and everybody got to know everybody, and it became a good situation for Sarah. Again, because hospice is focused on the person who is experiencing the illness. Hospice, as was also mentioned, very much support for family. And the social worker also that was mentioned would meet with us usually once a month just to make sure that we still had it all together and we were doing okay. And we were. So we had monthly visits with her. We would see the doctor from the hospice occasionally, not very often, but there wasn't any need to. She was on very few medicines because of her diagnosis just didn't require a lot of medication. She had a little bit of anxiety things that she would take at night to calm her down so she could sleep. But other than that, she basically didn't have any medications at all. Well, for 3.5 years, and then all of a sudden, then we hit March of 2020, and we all know what happened in March of 2020. Well, one day I could go see her, the next day I was told I couldn't even go in healthcare. And it stayed that way for about 9 months, as you all, if you've been here, experienced the same thing. My daily visits with Sarah, my feeding her, all that came to a screeching halt in one day. During those 9 months when I couldn't see her, a couple of things as far as hospice was concerned evolved. One is there was about 6 weeks that hospice people couldn't even go in. So nobody was going into healthcare at Lakewood for about 6 weeks. Probably a similar situation here as well. And during that time, my only communication with her was FaceTime. The activities people at Lakewood and also her evening Lakewood CNA person would visit, and she would FaceTime with us. So I got to talk with her 4 or 5 times a week. And we would carry on our conversations with that. It even got to where the CNA became part of our conversations because she became part of the family. The family, the togetherness with hospice is so important, and for us it worked. Now I know some situations it doesn't. Some situations hospice is very short, a very short period of time before a person passes. But in our situation, we had hospice service for a long time, and it worked. And never was there a moment. Well, of course, she had to have the checkups to make sure she was still eligible and all that. The nurses did that, and she remained eligible. And then during COVID, this would have been in July after March, I got a call from hospice and said that she had plateaued. Now, that for family, that translates into, oh my. Well, what it translated for me and our family was that they were trying to take her out of hospice, they being Medicare. The government was trying to take her out of hospice, and they succeeded. I appealed it. I went through the appeal process. It was denied through the appeal process, so Sarah didn't have any services. And remember, this is while COVID is going on. So I don't really know what happened during those days other than when we would have our conversations over FaceTime. It was entirely in the nursing staff at our community. She survived. I have no idea how many times she saw people. I have a feeling it was very limited because initially, you may not if you weren't in healthcare, but doctors and nurses and everybody had to put on this PPC or whatever it was, all that garments. They had to wear these masks. They had these aprons. I mean, it was tough. And every time a CNA would go from room to room, they'd have to take off all their clothes, their protective stuff, and then put on new protective stuff just to go to next door. So, I mean, that's the kind of thing that the CNAs and the nurses within the facilities, I'm sure the same thing happened here. That's what they had to live with and had to deal with, and that was tough. And of course, when you have to do that, that cuts down the actual physical time that a person can stay with a residence, or with, in this case, my wife Sarah. When I was finally able to go back in to see her, which was in February of the following year, I could see a change. And the change was that she was not near as active, but again, the disease progresses and continues on, but she still was not eligible for hospice. So then in May seemed to be the month. And then in May of 2021, she took a turn for the worse real quickly. And we immediately called the hospice people, and everybody agreed, yes, she's eligible for hospice again. So Memorial Day weekend of 2021, somebody mentioned it's not 24-hour care. Well, that particular weekend, we had about as close to 24-hour care as you're going to get, I would think. The nurse came on Friday, Saturday, Sunday, and Monday and Tuesday. My wife died on Wednesday. So those last 6 or 8 days, I don't know, 5 or 6 days, we had the hospice nurse in with us on a lot of times, and she talked with me a good bit about what I could expect. She was a believer, a Christian, as am I, and she and I had some conversations about what life will be like for me, and all that was all, again, offering support to me, the caregiver, versus for Sarah, because at that point, Sarah, again, was totally unresponsive, and she just lost it very quickly. But the hospice people, again, stepped right up and came in and offered us all kinds of comfort care. They gave Sarah medications as needed, and the last few days for her were very, very peaceful. And we did fine with it too. I mean, as far as fine can be, in that we knew the end was close. And then the second day of June in 2021, she took her last breath and left us. So hospice was with us all the way. Also was mentioned help for family after passing. We had help from the hospice people with that as well. The chaplain came to see us. We did not request and did not feel we needed the chaplain service that hospice offered during Sarah's illness, because our church family stepped up and came to see us on a regular basis, and regular being multiple times a week for different people from the church. So we didn't feel we needed the hospice chaplain service, though I'm sure it would have been very beneficial if we didn't have the other backup that we had. But that's kind of my story. It was a 5 years and about 5 years and 2 months journey from the time of her initial entering into healthcare until she passed. And I can't thank hospice enough for that particular service, for us, for our family, and what it did for her as well. So that's kind of my story of 5+ years.
Does anyone have any questions they'd like to ask any of our panel members?
I have 2 questions, although I think the second one's already been answered. The first question is, when you say volunteer services, can you just tell me a couple of what kind of volunteer services they are?
Can you hear me? Can you hear me? You can hear me? Okay. Can you hear me? Okay. So we have a volunteer coordinator, and we have hospice volunteers, a group of hospice volunteers. Here at Cedarfield specifically, though, you have hospice volunteers that are neighbor to neighbor. So our hospice company has volunteers, but at Cedarfield, you have kind of a different flavor under the volunteer program, where you'll have neighbors that will visit you, and Emily is in charge of that and coordinates that. But outside of Cedarfield, we have families, if they're interested in volunteer services, they let the nurse case manager know, and then that volunteer coordinator contacts the family members who have requested the volunteer and kind of gets some information on interests and how they would like the volunteer to be utilized, so that we can make sure we make a good fit, and then that volunteer is coordinated to make visits.
So that's just visits,
Mhm.
social visits.
Yes.
Okay, my second question is, what happens if the person is deemed that they are going to die, but they don't know when? I had a friend who, I think he had pancreatic cancer, and the doctor said, nobody knows but God, 2 weeks to a year. So how does that, would that make him hospice eligible?
Yeah, good question. A lot of it depends on the diagnosis. We know with certain diagnoses like pancreatic cancer, for example, we know the prognosis is poor, 6 months, 9 months, depending on the total scenario. And you have to look at the whole picture. Yeah, the doctor should be able to tell, or at least as a hospice physician, been doing this for a long time, I can tell looking at everything. We look at weight loss, we look at functional status, we look at lots of other different prognostic variables, if you will. That gives us a good idea as to whether or not the patient's going to die in a week, a month, 6 months, a year. So that's kind of what we look at. We kind of look at the whole picture, and that kind
And
of
would
makes
he
that.
be eligible then for hospice?
Yes,
Okay, thank you.
yes, ma'am.
This is a comment, not a question. I would encourage family members and patients to seek hospice sooner rather than later. All too often, people wait till the last week, and it's not the good experience it could be.
Good point. Hospice provides a lot of services, especially early on, which will ease things at the very end. So that's a good point, and that's one of the problems that we do have with hospice is most families wait until the very end, and unfortunately, a lot of doctors also wait until the very end to get hospice involved with their patients.
The experience that I had with the hospice in that situation uh, was we immediately, as soon as she came back from the hospital with the diagnosis that she had with her brain bleed, uh, she was eligible immediately, and we got the services started immediately for her. And it's just such a blessing. And if you don't carry anything much out of this other than today, is the sooner rather than later with asking and trying to get for hospice services is very beneficial to both the receiver of the services and the family as well. So I encourage that a lot. Be sure you do that as soon as you can, right? Sooner rather than later.
One other thing that I'll mention with hospice is if you decide you want to come on to hospice, now all of a sudden things have changed, your clinical condition has improved, or you want to seek more aggressive treatment, you are in charge. The patient, the family is in charge. You have the autonomy. You could say, I want to stop hospice services and I want to seek aggressive treatment. That's fine. That's your prerogative. You can do that.
First, thank you for Bill for the personal remarks, and I'm a little bit. I have a question coming up, but I'm a little bit uncertain as to doctor and nurse. Are you? Do you provide services at Cedarfield, for example? Okay, so that led to my question, which was, why do we have Lakewood over here? And I say that in all candor and honesty. Thank you, Bill. But what's the experience at Cedarfield?
Invited him, so I'll be happy to. Yes. So I was actually invited over to Lakewood at one time, and Bill and I did a forum together. And as a hospice nurse for going on 12 years now, I found his experience to be very vast. And being discharged for extended prognosis not once but twice, and that doesn't happen typically. And over a 5-year span. And I think that myth of that 6 month or less, or patients who come on much later, as discussed earlier, within weeks of death, his experience shares that there are opportunities there for hospice support within a 5-year period when you have a chronic illness or a terminal diagnosis, and that we don't know when someone's life is going to end. And we try to support families the best that we can. So I felt that Bill's experience would fit in very well here, even as an outsider.
Currently, I have 2 siblings. Both are in hospice in different states. Now, my question is, how often the review process? They review every 2 months, or 3 months, or 6 months?
So initially, the first review is 90 days, and after that 90 days, it's every 60 days.
So 2 months. Thank you.
Every patient's case is discussed at least every 2 weeks. So it is reviewed every 2 weeks as far as the interdisciplinary team. Usually the determination as far as hospice appropriateness, that is, as Patty had said, it's every eligibility, it's every 3 months, 3 months, and then every 2 months thereafter.
No other questions? Okay.
Well,
Well,
you had mentioned when we walked in about medical aid in dying. Anyone heard that term, medical aid in dying? I just want to clarify that. Essentially, what that is, and it's not legal in the state of Virginia, it's being discussed in the General Assembly, but medical aid in dying is essentially physician assisted suicide, if you will, where the two physicians have to determine that a patient's prognosis is truly less than 6 months. The patient has to pretty much be cognizant enough to give consent to that, or their family has to give consent to that. And the physician will write medications for that. And then either the family or the patient will give the medication to the patient to terminate their life. Again, that's not legal in Virginia yet. It's being discussed in the General Assembly. And I think there's 13 or 14 states in the country now where it is legal. So in case you ever hear that term, medical aid in dying or physician assisted death, physician assisted aid in dying, that's what that is. It's
Can you tell a little bit about the short-term respite care? It's the caretaker going somewhere for a week? What happened to the patient?
Yes. So if a family requests respite services, the social worker assigned to their case can coordinate that for them. The way that works is if they're in a home, then the social worker finds different skilled nursing facilities or facilities that offer that hospice care. So it's based on availability. And once she is able to find a couple of places where they have availability, she'll let the family know. The family can visit and determine, which community they would or facility they would like their loved one to go to for that 5 days. And then we follow the patient there. We go over, write orders, and manage their care while they're there, arrange transportation for them to get there, and then arrange transportation at the end of the 5 days for them to come back to their home. And then we get them set back up on services and make sure they have what they need when they return home.
Thank you.
I will just add, all of you are residents here at Cedarfield, that if you are on hospice services and you live in independent living, and maybe you have that situation where your spouse or somebody else is a caretaker for you, and they need to go somewhere and you need to come to healthcare or assisted living for respite, that's certainly something we could help arrange for you. We have had people in all levels of care here at Cedarfield on hospice services. So the social workers and your doctor and the nursing team here would help coordinate with whatever hospice company you're using to make sure you're receiving care and the correct level of care and all of that. All right, well, we'll be here for a few minutes after if you guys, want to come up and, ask a personal question or something like that. But thank you all for coming. All right.